we have one of our orthopedic residents, Mindy Galleher, who will be presenting on evaluating and treating hamstring strains. Oh my God, yeah, give her a round there. If you want.
Okay, hi everyone. I'm Mindy. I'm one of the orthopedic residents here at Children's. Bree is passing around right now just an evaluation form for my presentation, so if you guys don't mind filling that out at some point and then turning it back in when you're done, I would really appreciate it. I'm going to be talking about evaluation and treatment of hamstring strains. So I learned a ton putting this presentation together, so my hope is that a little bit of that new knowledge that I gained is going to transfer over to you all. I'm hoping that you'll be able to understand a few different types of hamstring injuries and their impacts on the healing and the rehab timeline. Understanding the different phases of rehab and some of the criteria to progress back to sport. Being able to understand some of the differential diagnosis tests that you can use with hamstring injuries. And then for the lab part of this lecture, which will be later on this afternoon with Christina, to understand and be able to demonstrate some higher level strengthening exercises used to aid in return to sport in this population. So just a little bit of the background and info on the impact of hamstring strains. This is the most common type of injury in your athletes. One study looked at 25 NCAA sports teams with their hamstring injury rate over the course of 4 years and found that men's football had the biggest impact with 35%, followed by men's soccer and then women's soccer. Approximately one third of those hamstring strains are recurrent, which to me is just a really outrageous number. And then many of those are within the first 2 weeks of return to sport. Again, really outrageous. Seems like a little bit too high, something that we need to work on getting down. So most of those injuries are going to be non-contact, and there really is no rhyme or reason as to whether they occur during competition or in the preseason. It's a little bit of both. The two most common mechanisms of injury for hamstring strains are going to be your high-speed running and then your overstretching. So with that high-speed running and sprinting, the hamstrings are going to be active, they're lengthening, they're absorbing energy. And that type of injury is usually going to involve the intramuscular tendon. So that's where that tendon kind of goes all the way through the muscle. There's not that nice muscle to tendon to bone transition. And it's more common to occur in the biceps femoris because that intramuscular tendon tends to run kind of throughout the entire muscle. With this kind of injury, it typically has a shorter convalescent period, which is just a shorter time kind of to return to that pre-level injury or pre-level health status. The second most common mechanism of injury is going to be your overstretching, so either goes fast or slow in ranges of motion that take you into full hip flexion and knee extension, so a little bit more common in your dancers, your gymnasts, your cheerleaders that are doing a lot of those high overhead kicking motions. This is more typically going to involve the proximal free tendon of the semimembranosus muscle, and it tends to be associated with that longer convalescent period. So one big takeaway point that I already got from this was that these two mechanisms of injury are very different. They're very different types of populations, types of patients, sports played, and yet you'll find that in the literature, in the research, these two mechanisms of injury don't really have significantly different rehab strategies. So as I mentioned before with the convalescent period, just to define that for you, that's going to be the gradual recovery of health and strength after injury, so kind of that return to sport. A greater or longer convalescent period is going to be associated more likely with your proximal free tendon injuries, those injuries that have a closer proximity to the ischial tuberosity, and then injuries with an increased length and cross-sectional area, so just those more, those higher grades of injury. With your examination, you're going to want to determine the location and the severity of the injury. You can use those results to kind of estimate the convalescent period, which can be really important to start educating your patients about right from the beginning, and then to design an appropriate rehab program based on your findings and individualized to your patient and to their sport as much as possible. Some specific outcome measures that you can use related to this particular type of injury are the Functional Assessment Scale for Acute Hamstring Injuries, the Victorian Institute of Sports Assessment for patients with high hamstring tendinopathy, and then the Tampa Scale for Kinesiophobia, which kinesiophobias or the lack thereof can be a good determinant for return to sport, and some articles or research studies do use that as a criteria for return to sport, so that's good to kind of get at your baseline. And then just some more basic outcome measures that are still appropriate for this patient population would be the hip outcome score, the lower extremity functional scale, your patient-specific functional scale, those types of measurements. So with your examination, you're going to want to first clear out the hip and the knee, ensure they have full and pain-free range of motion at those joints, and then you're going to want to check out the flexibility or the length of your hamstring muscle. You can look at the passive straight leg raise or an active knee extension test using either a goni or an inclinometer, kind of whatever tool you prefer. And then the passive hip abduction to kind of assess the adductor involvement and rule in or rule out any involvement or limitations there. It's important to remember that acutely motion is going to be primarily limited by pain, so frequent reassessment as their pain kind of goes down is going to be important throughout the rehab program. And then remember, in your dancers, your gymnasts, your more flexible individuals, they're going to be expected to be needing a good amount more flexibility than the norms listed up there. So kind of looking at the contralateral side, checking out the flexibility there and using that as your goal, not necessarily just norms or what you would expect for a normal hamstring length. When looking at strength, you want to make sure you're not just checking out the strength, but looking for pain provocation to try and really isolate which muscles are involved, which muscles are not involved. With hip extension, you want to check that with the knee fully extended and then also 90 degrees of flexion. That way you're looking with the knee fully extended, you're kind of checking out the involvement, the impact of the hamstring injury to that hip extension strength. And then you want to check it again at 90 degrees to kind of try to get the hamstrings a little bit shortened, really isolate the glutes a little bit more, make sure those are nice and strong. With knee flexion, again, you're going to want to look at both 90 and 15 degrees of knee flexion with that MMT testing. At 90 degrees is just kind of your standard mid-range strength, but looking at it in 15 degrees of knee flexion, that way you're really checking out that end range of motion, that strength with the muscle in a lengthened position, because that's, again, going to be really important for return to sport. And then the active knee flexion test, which is the patient in prone, and you can have their knee beginning at 90 degrees of knee flexion, and then the patient is going to resist you as you kind of extend their knee slowly down to 30. So that's really going to kind of recreate that eccentric load mechanism, check out the strength of the hamstring while they are kind of eccentrically contracting. In some of those lower grade injuries, this is going to be maybe the only way that you can reproduce their pain symptoms if they're not very acute, not very irritable. So that's kind of a good test if you're not really seeing many limitations with hip extension or knee flexion strength. For palpation, you will not always see a very nice palpable defect like in this picture, but you do want to look for a palpable defect or just that point of maximum tenderness to palpation. That distance of the point of maximum tenderness from the ischial tuberosity can be associated with the convalescent period. So the closer it is to the isch tube, the longer the rehab program is probably going to take. Oftentimes these patients are going to either be non-tender to palpation or very globally tender to palpation. So you might not be able to get that nice pinpoint and get a measurement. But if you can, again, it's so important just to kind of add that to your education to your patient about how long their rehab program is going to take, the risk of re-injury if they're returning too soon. Those points of education are so important to start as early as possible to kind of improve the compliance of your patients with your program. Again, checking out the adductors, ruling in or ruling out that adductor muscle bulk as any kind of involvement, and also not forgetting about the adductor magnus. That muscle is very intertwined with the semimembranosus, so they're going to be in a close proximity, and that muscle is also a hip extensor through a large range of hip flexion motion, so it can be involved in these kinds of injuries. There's a long list of differential diagnoses for this disorder. We are going to hone in on a couple of specific ones, so the high hamstring tendinopathy and the hamstring strain, and diving in a little bit deeper, or the hamstring syndrome, and diving in a little bit deeper to those and how to differentiate those from just your typical hamstring strain. X-rays are are not always beneficial in terms of ruling in or ruling out a hamstring strain, obviously, but they can be good for ruling out an avulsion fracture. So if you have those, it's a great thing to take advantage of. More commonly, the MRI is going to be used for diagnosing and then grading the injury, and also dynamic ultrasound can also be utilized as a diagnostic tool if you have the resources. When diagnosing based on clinical exam, you can diagnose based on a very mild grade 1 injury, which is just that overstretching with minimal loss of structural integrity, all the way to a complete rupture. And again, the prognosis is so important to start sharing with your patient right away, educating them that they may have a longer time to full recovery if they have a more proximal injury, if they have a larger tear visualized on imaging, a greater reduction in motion. And an interesting education point is just educating on that increased time to walk pain-free. So if it's greater than 1 day, it may be greater than 3 weeks before return to sport. And if it's less than 1 day, they're more likely going to be able to return in less than 3 weeks. So, hamstring syndrome. This is an interesting diagnosis that often goes overlooked in patients with kind of that chronic and recurrent hamstring strain. Essentially, it is an irritation of the sciatic nerve by the hamstring muscle at or around the ischial tuberosity. Unfortunately, the clinical presentation of hamstring syndrome is very similar to your typical hamstring strain. There are not a lot of great points that differentiate the two. You're often going to have that pain in the posterior thigh, possibly a sprinting or running or hurdling type mechanism of injury, pain with sitting, history of recurrent hamstring strains. All of those would kind of lead you down the road of a typical hamstring strain, but it could also be this. So just a couple points of ruling in or ruling out specifically this syndrome would be that supine resisted knee flexion with the hip in 90 degrees and the knee extended to the limit is more likely going to be painful. They could have a positive slump or a positive straight leg raise. So important to rule that in or out. And then weakness at 30 degrees of resisted knee flexion, as well as tenderness to palpation at the ischial tuberosity. Unfortunately, there's not a lot out there in the literature on treatment of hamstring syndrome, but a few things that we do know is that stretching is not going to be indicated, and more often than not is going to exacerbate the symptoms and kind of worsen the problem. So that's something that you want to stay away with if you're leaning towards the fact that your patient might be suffering from hamstring syndrome. Neuromobilizations are going to be a great idea for these patients. So something that's distally initiated, those nerve flies, that just on and off tensioning of the muscle, of the nerve, getting it moving a little bit better, is going to be very beneficial. So the patient in the picture, they're going to be laterally flexed towards the symptomatic side. Their hip is flexed to 45, abducted to 30 degrees, and then the knee is just up and supported on those pillows. Some kind of a sheet or a loop of some sort that can maintain their foot and ankle in that end-range dorsiflexion, and then just tensioning on and off with repetitive knee flexion and extension, anywhere from 30 to 120 repetitions. So depending on how irritable they are with these, you might want to start with a lower count, but if you feel like they're getting a little better but not quite there with it, all the way up to 120 repetitions might be indicated for your patient. A couple other pain modification activities that they can do would be sitting on a wedge with the wider side position dorsally, and then also iontophoresis in the gluteal region. Another disorder I wanted to talk about that can often present very similarly to just a hamstring strain would be that proximal hamstring tendinopathy, which is just that typical overuse where that fibrosis of the hamstrings can develop at the ischial tuberosity. This degenerative tendinopathy may also include a sciatic nerve irritation. So again, very similar in presentation to hamstring syndrome. Important to be able to rule in or rule out and differentiate between those two things. Also, a side note that I discovered while putting together this presentation is that in the literature, this proximal or high hamstring tendinopathy and hamstring syndrome can even be kind of literature, or the words can be used, or the phrases are used interchangeably. So if you find that you're kind of looking into this, looking for a case report, something specific to your patient, and you wanted to do a little background or a little research on it, just be very cautious of reading the definitions and the introduction and really diving into what they're talking about before just kind of skipping to the discussion and the results and looking at that part, because I found that a few different studies kind of use them interchangeably. For proximal hamstring tendinopathy, the clinical presentation, again, very similar to just a basic hamstring strain. They're going to have that repetitive history of injury. They're going to be that middle distance or long distance runner, maybe a soccer player. They are going to have that ill-defined pain in the ischial tuberosity area. A couple things to help differentiate this from hamstring syndrome would be that, the slump and the straight leg raise are more likely going to be negative. They might have tenderness to palpation at the ischial tuberosity and pain with resisted knee flexion. But one interesting test that you can do to provoke this is the hamstring eccentric provocation test, which is a little bit different. So the patient is just kind of standing and prone over a table, and they've got their hip flexed and knee flexed minimally, and then applying a downward pressure at the foot and ankle to kind of recreate that eccentric load. Sometimes a good way to provoke this in one of those less painful or less irritable cases. A few special tests that are specific and have been talked about in the literature a good amount for diagnosing proximal hamstring tendinopathy. The Puranen-Oreva test is just essentially a standing hamstring test, which is in that picture. And just looking for pain provocation or reproduction. The bent knee stretch test, which is patient supine, and the examiner is going to want to maximally flex the hip and knee, and then passively and slowly extend the knee. And then the modified bent knee stretch test is very similar, but it just adds kind of a rapid knee extension instead of that slow passive knee extension to that motion. So all three have been supported in the literature for diagnosis of proximal hamstring tendinopathy, with the modified bent knee stretch test kind of showing the best sensitivity, specificity, and those positive and negative likelihood ratios, all ranging between around 89 to 91%. So if you're going to choose one, that's probably the best one. And then this is just the illustration of the modified bent knee stretch test. A couple of interesting treatment options and things that differ with hamstring tendinopathy. One article I found in JOSPT kind of talked about avoiding hip flexion in the beginning stages of strengthening, so trying to keep the hip more in a neutral position when you're working on strengthening. Some ways they recommended that were those, prone isometric hamstring curls, the exercise in the bottom picture, so that trunk extensions, just an isometric leg pull down, and then isometric bridge holds in that neutral position. Another exercise that I found interesting that was recommended for more in the later stages of rehab is this top photo here. It's called hip press, and essentially it's just a modified form of bridging that really focuses on beginning a more hip flex angle, so with the foot supported on the floor and the shoulders supported on some kind of a low bench. They found that in EMG studies, the glute max was actually a little bit more active during this exercise than the biceps femoris. So just a good exercise if you're working with one of those patients that's maybe a little bit more hamstring dominant, glute weak, and you really want to start strengthening those glutes a little bit over the hamstring. And then just some other options. So a couple case studies looked at instrument-assisted soft tissue mobilization with these patients, having some success, some cross-friction massage, gentle stretching, dry needling, a lot of basic principles that you might use with any other tendinopathy as well. Okay, so getting into hamstring strains and the rehab progression. In that phase one, that very acute phase shortly after their injury, you're going to want to start with activity modification depending on how irritable and how severe the injury was. So that could be anything from just holding from running and doing more cross-training, some more biking, swimming, those kinds of activities, all the way ranging to ambulating with crutches and doing kind of a shortened stride length. It's important with these patients to have them kind of not hold in that isometric knee flexion position if they are using crutches. So really educating on that partial weight bearing or weight bearing as tolerated gait pattern with a shortened stride length is going to be more beneficial for these patients and less likely to kind of strain that injured tissue. Icing as needed for pain management, avoiding stretching the tissue in the early phases, really letting it heal so we don't develop any scar tissue in the area. Therapeutic exercises that you can begin safely in these phases are going to want to focus on that dynamic and neuromuscular control without really stressing the injured tissue. So submaximal isometrics, working on their single leg balance, and working on a lot of frontal plane exercises or activities, kind of avoiding that sagittal plane motion so that we're not stressing the tissue. So grapevine, sidestepping, starting at a very low intensity and progressing as they're able to tolerate. So maybe adding some TheraBand resistance to their sidestepping drills, things like that. Trying to keep everything pain-free in this phase. To progress to the next phase, you want to have the patient doing normal walking stride without any pain, some very, very light jogging without pain, and then having a pain-free prone knee flexion test at that standard 90 degrees of knee flexion, which is submaximal resistance, so 50 to 70% is all. So you want to make sure you're not doing your basic MMT where you're really trying to break them in that position, but just having to be able to pain-free resist a little bit of your resistance. If they're able to do all of that, you can move on to the second phase, which you're still going to want to be avoiding that end range lengthening or stretching, especially if weakness is persisting. Continue to ice as needed. Manual therapy is a good idea to start at this phase. So either that soft tissue massage to try and help prevent scar tissue formation, but also looking at joints above and below the injured area and making sure they have normalized flexibility and joint mobility there. So really taking into consideration that regional interdependence, looking at maybe if they have limited ankle motion, do they have limited talocrural joint mobility? Is that something that you can normalize to prevent re-injury? Something that often goes overlooked. For therapeutic exercise, again, emphasizing that neuromuscular control, agility drills, trunk stabilization, starting to get into some concentric and eccentric strengthening of the hamstring muscle, and kind of progressing from that frontal and transverse plane motion to getting into that sagittal plane motion a little bit as they can tolerate. Also in this phase, you can kind of start some sport-specific skills. So just a couple exercises I found that are a nice, easy progression from just strictly frontal plane motion to adding a little bit of sagittal would be like the boxer's shuffle. So there's just getting into a little bit of that sagittal plane motion. It's still pretty limited. It's something where you can start out very slow and then start working on speed and agility, even though it's still kind of an earlier phase of rehab. And then another exercise that's commonly recommended in this phase is the rotating body bridge. So really great full body and core exercise, still not stressing the hamstring too much, working on that strength and neuromuscular control. A couple other strengthening ideas in this phase, which will be covered a little bit more in depth in the lab part of this lecture, but some bridge walkouts, which are in the picture, the glider, which is just using your slide board and having them do kind of a retro lunge with that non-injured leg, having to kind of stabilize and do all of the work with their injured side. Some windmill touches to start getting into that eccentric strengthening, and then high-to-low wood chops, which is just kind of a great way to work in some core strengthening. Progression criteria in this phase, you want to look for 5 out of 5 that pain-free MMT with maximal resistance, both at 30 and 90 degrees. So still not quite expecting it to be 100% at that end range, but we're nearing that end range motion of the hamstring. So we're starting to look for that strength in a more lengthened position. Again, something that goes overlooked, but a lot of patients can be super, super strong at this point at 90 degrees in that mid-range and then still be very weak at that 30 degree. So making sure you're looking at both of those things before you progress them. And also forward and backward jogging at 50% max speed without pain, so that way you're looking at stressing the hamstring kind of in a concentric and eccentric fashion and making sure that both of those are pain-free. For the last phase, really the only thing that we're still avoiding is that sprinting and explosive acceleration. They should be getting into a lot of other sports-specific activities at this point, though, if they can tolerate it. Still icing as needed. Stretching should no longer be limited, so this is where you want to kind of normalize, make sure you're checking the opposite side, making sure they have that flexibility in the hamstring muscle. And then you really want to start getting into some agility and sports-specific training. So some challenging trunk stabilization, really working on eccentrics, progressing towards that end range of motion, making sure they can tolerate those and control them well. And then starting to get into some quick directional changes and technique training. So a little bit more about eccentrics, just to really emphasize the importance of these, because a lot of studies support that kind of after a hamstring strain or injury, that muscle is going to have a shortened force-length relationship. So essentially, peak forces are going to occur at that shorter hamstring muscle, or when it's in a shortened length, it's going to be at its strongest. And then with the eccentric exercises, we can kind of reshift that peak force production to those longer muscle lengths. So making sure the muscle is strong at that end range of motion. Because again, that common mechanism of injury is the overstretching and the sprinting, where your muscle is kind of lengthening and absorbing energy at its end ranges. So that's where we need it to be important, which eccentric exercises have been shown to help with that. So we're just trying to kind of optimally restore that musculotendon length to help reduce the risk of re-injury. Just a couple other exercises that you can utilize in this phase. So a single leg chair bridge, single leg windmills, which are in the photo, adding that dumbbell resistance, a T-lift lunge walk. A lot of these are focusing on full body, but also those eccentrics. Something that sometimes goes overlooked in anything besides our ACL patients would be implementing plyometrics at those kind of end stages of rehab. So if any of your athletes are getting back to any kind of explosive activity that requires power and strength, then plyometrics are something that you should be working into those end phases of rehab. You can, as long as your patient is tolerating moderate loading, which they should be by this phase, you should be able to start working in plyometrics. You can begin with those non-weight bearing plyometrics, as in the picture at the bottom, so using a shuttle or a total gym. That way they're not putting their full body weight through their legs if you want to kind of start them very easy. Some more examples of plyos that you can include, not in any particular order or recommendation, just a few examples. So box jumps, step jumps, ranging all the way to squat jumps with a 90 or 180 degree turn. With plyometrics, it's just important to remember you want to start with a good focus on those mechanics both during takeoff and landing. Make sure they're not demonstrating that pelvis collapse. They don't have a ton of anterior knee translation. They have a nice soft landing, and they're tolerating it well with those just simple jumps, and then progressing to the more dynamic change of directions, repetitive with a rebound kind of activities. Again, hop testing, something that's really emphasized kind of in our ACL rehab literature, but something that I think can really apply to this patient population as well. It's just a great way to kind of assess your patient's neuromuscular control, their strength and their confidence in the limb as they're in this kind of final phase of rehab prior to return to sport. So if you're not familiar, it's just going to be that single hop for distance, triple hop for distance, a crossover, and then a 6-meter timed hop for distance. Oftentimes beginning with that single hop for distance, making sure they can tolerate it. Again, demonstrate good jumping and landing mechanics. And looking for that 85 to 90% limb symmetry index from side to side. So essentially what that is you're hoping that the symptomatic limb is going to jump at least 85 to 90% as far as the symptomatic limb did. So just dividing one by the other, and that'll give you that percentage of LSI. And this is just a little visual on all 4 tests. So for return to play, unfortunately in the research there is no consensus on return to play criteria for this patient population. So this is just kind of taking information from a lot of different studies and compiling it all together. So different things that you want to look at are you expect full range of motion, strength, and full abilities with their functional abilities, so jumping, running, cutting, doing their sports-specific activities without any complaints of pain or stiffness during or within the first 24 hours after. You want to have pain-free palpation over the site of the injury, and no fear or kinesiophobia. So that can either be tested with one of those subjective outcome measures, or with an actual test, so the Asling H test, which is essentially going to be a faster ballistic straight leg raise in the supine position, and then just comparing side to side and ensuring that they have kind of the confidence and no fear with getting that leg kind of up there and lengthening that muscle quickly. You also want to see strength and endurance with MMT testing at both 90 and now that 15 degrees of prone knee flexion. So you want to have 4 consecutive pain-free repetitions of each. And then high-speed running drills without experience of pain or discomfort. And again, that 85 to 90% limb symmetry index with hot testing if you choose to use that. Future directions that research is hopefully going to go to is going to be to looking at getting a rehab program for not just those running-related or running-specific hamstring strains, but also looking into something for those overstretching injuries, because we really do need to differentiate between the two. So establishing the most appropriate rehab strategies for those injuries to the proximal free tendon, and then informing on those current practices and those widely published rehab protocols that we do have out there, kind of validating them and getting a consensus on return to play criteria for this patient population. Does anybody have any questions?
What suggestions do you have on injury prevention? It's such a common injury.
Injury prevention. There's a lot of great information out there on injury prevention, but a lot of that comes kind of within the return to play criteria. So making sure that they're staying strong, they're staying flexible, they're working on running, jumping, cutting, going in all of those different directions, keeping up on neuromuscular control, so trunk stability, those kinds of activities are really stressed in that prevention of re-injury. Those kinds of things. Any other questions? All right, thanks everyone.
We'll do a 10-minute break. Let's start back with Michael. Still a lot of coffee and food back here. So.